بسم الله الرحمن الرحيم. في الجون هوبكنز combined aortic valve replacement with coronary artery disease. Many patients with valvular aortic disease have concomitant coronary artery disease, but the data are limited regarding the optimal strategies for diagnosis and treatment of coronary artery disease in such patients. Ischemic symptoms in patients with aortic valve disease may have multiple causes. Ischemic symptoms in patients with aortic valve disease may have multiple causes, such as left ventricular chamber enlargement, increased wall stress and wall thickening, with subendocardial ischemia, and right ventricular hypertrophy. Because angina is a poor marker of coronary artery disease in these patients, coronary angiography is recommended in symptomatic patients before aortic valve replacement. A coronary angiography or arteriography is recommended in symptomatic patients before aortic valve replacement, especially in men older than 35 years of age, premenopausal women older than 35 years of age with coronary risk factors, and postmenopausal women. Greater than one-third of patients with aortic stenosis undergoing aortic valve replacement surgery have concomitant coronary artery disease. Population studies have shown that more than 50% of patients أكثر من 70 years old have coronary artery disease. Combined coronary artery bypass surgery at the time of aortic surgery or aortic valve replacement has had little or no adverse effects on operative mortality. In addition, coronary bypass grafting at the time of AVR reduces the rate of perioperative myocardial infarction, operative mortality, and late mortality and morbidity compared with patients with significant coronary artery disease who do not undergo revascularization at the time of aortic valve replacement. Incomplete revascularization is associated with greater postoperative systolic dysfunction and reduced survival rates after surgery compared with patients who receive complete revascularization. Over the past decade, improved anesthesia and myocardial preservation techniques have been associated with reduced overall operative mortality, and it has become a standard practice to surgically bypass all significant coronary stenosis when possible in patients undergoing AVR. It is well agreed upon that all patients undergoing coronary artery bypass surgery who have severe aortic stenosis, symptomatic or not, should undergo aortic valve replacement at the time of revascularization. Decision making is more difficult in patients with mild to moderate aortic stenosis who have concomitant coronary artery disease requiring CABG. Controversy persists regarding the indication for the so-called prophylactic valve replacement at the time of coronary bypass surgery in such patients. Controversy persists regarding the indication for the so-called prophylactic valve replacement at the time of CABG surgery in such patients. It is difficult to predict whether a given patient with CAD and mild aortic stenosis is likely to develop clinically significant aortic stenosis after revascularization. The natural history of mild aortic stenosis is variable, with some patients manifesting a rapid progression of their disease, with a decrease in valve area of up to 3 square centimeter per year. A decrease in valve area of up to 3 square centimeter per year, and the increase in the pressure gradient 15 ل 19 millimeter Hg per year. The average rate of reduction of valve area 1 square centimeter per year, but the rate of change is in an individual patient is difficult to predict or foresee. Phillips et al. Reviewed MEAT patients who underwent aortic valve replacement after previous coronary artery bypass grafting, where the mean valve gradient was less than 25 millimeter at the time of initial operation. The mean time interval to reoperation was 9 years. The mean time interval to reoperation was 9 years, and the overall operative mortality was 7%. The authors concluded that, given the relatively long time interval between the two operations and the significant decline in reoperative mortality rate in recent years, an expected approach to concomitant aortic valve replacement and CABG is warranted. Karagunas and associates reviewed 200 patients requiring a cabbage who all had aortic stenosis with a peak gradient less than or equal 40. Of these 46 underwent combined AVR and cabbage at first operation. Over a median follow-up period of 4 years, none of the patients who had cabbage only at first operation required re-operation for AVR. From these data, the authors recommended cabbage only for patients with mild aortic stenosis. In contrast, Ahmed and colleagues followed 40 patients with mild to moderate aortic stenosis who underwent cabbage without aortic valve replacement. 11 patients in this study group required re-operation for aortic valve replacement. Similarly, Hochrein and associates noted 24% AVR re-operation rate over 6 years period in patients receiving a cabbage alone versus 3% in patients who underwent AVR combined with cabbage at initial operation. The results of these two studies suggest that aortic valve replacement is reasonable at the time of initial cabbage in this patient population. Smith et al. Performed decision analysis based on Society of Thoracic Surgery National Database and have submitted the following recommendation. For patients under the age of 70 years, AVR for mild aortic stenosis is recommended if the peak valve gradient 25-30. For older patients, the threshold gradient increased by 1 to 2 mm Hg per year of age. Also, cabbage only is favored in patients with a slow أقل من 3 mm per year progression of aortic stenosis, in contrast to those with rapid progression أكتر من 10 mm Hg per year, who should have combined cabbage and AVR, with the possible exception of patients أكتر من 80 years old who have valve gradient أقل من 25 mm Hg. At the time of surgery, the choice of prosthesis does not influence the overall survival. The choice of prosthesis does not influence the overall survival, but a bioprosthetic valve is likely more appropriate in this setting because of the increased complications related to the anticoagulation with mechanical valves, and because that decreased patient longevity in patients with significant coronary artery disease undergoing aortic valve replacement, which makes structural valve deterioration much less likely. بعد كده aortic valve replacement in end stage renal disease. aortic valve replacement في العيانين اللي عندهم renal disease. بعد كده الاندوكاردايتس، ثم الاورتيك فالف ريبليسمنت فولوينج mediastinal radiation، والبيركوتينيوس اورتيك فالف ريبليسمنت. تافي بقى. يبقى احنا فاضل لنا 3 مواضيع. ايه هم ال3 مواضيع؟ رقم 1 الاورتيك فالف ريبليسمنت في عيانين الرينال فيلير، ورقم 2 الاندوكاردايتس، رقم 3 الميدياستاينال راديشن، رقم 4 بيركوتينيوس اورتيك فالف ريبليسمنت. 4 مواضيع.